we have really a great opportunity to hear about a very topical and interesting application of Bayesian network technology, which is related to modelling COVID-19, and our plenary speakers today are going to be telling us about that project, which has been happening this year. So we have Professor Tom Snelling, who is a paediatric infectious diseases physician, an epidemiologist. That's the job of 2020, I suspect, and a professor of the School of Public Health at the University of Sydney, where he leads the Health and Clinical Analytics Lab. He has a number of honorary affiliations, including with the Telethon Kids Institute, the Menzies School of Health Research, and the University of Western Australia and Curtin Universities. Those Western Australian affiliations, because until a year or so ago, he was the director of the Wesfarmers Centre of Vaccines and Infectious Diseases at the Telethon Kids Institute in Perth. But then he's now moved to the University of Sydney and has a Sydney Health affiliation as well. So Tom's really a pioneer in the design, coordination, implementation, analysis of Bayesian trials in the Australian medical scene. That includes trials on the management and prevention of gastroenteritis in Aboriginal children, and primary prevention of allergy and other areas. He's also, though, been a pioneer in the adoption of using Bayesian network modelling techniques, and that's what we're going to be hearing about today. Second, and part of the presentation team is Stephen Mascaro, and it's a particular pleasure for me to introduce Stephen today because a number of years ago, he was a PhD student of mine and Kevin Corb's at Monash University. Starting off actually as our honours student and then moving on to a PhD. And Stephen's one of these amazing people that is very broad in his skills and knowledge. So he actually did his PhD in artificial life simulation, but along the way with Kevin and myself, he did pick up quite a bit about Bayesian networks. And then after his PhD, he moved into working his research and then consulting company Bayesian Intelligence, primarily focusing on Bayesian network modelling. And as many of you know, he's been involved for many years with the Bayesian Network Modelling Society. So Stephen is the lead modelling person on the COVID-19 project as well. Anyway, so that gives you the background of our speakers, and it's my pleasure now to, I think, hand over to Tom. Is that right? I'm not quite sure who's coordinating this, so Tom is going to start off, I believe. Welcome.
Thanks, Anne. Can you hear me okay?
Yep, that's great.
Great, okay. So yeah, thank you for that introduction. And as you said, I'm a infectious diseases physician by training, and I want to start by sort of presenting the motivation for this work, and then hand over to Stephen to provide more of the technical detail. But this has been a project that's involved many people. A lot of the work has been supported by the Digital Health CRC as a collaboration with between Sydney University, Monash University and Queensland University of Technology. And we've also had support for this work from the Prize and the Creed Centres for Research Excellence in Pandemic Preparedness, and from the Snow Medical Foundation. So just in case you've been asleep for the past 12 months, this is a quick snapshot of how we've got to where we are. So it just started on the 30th of December of last year, so not quite 12 months ago, when a 34-year-old doctor from China alerted his fellow doctors that he was seeing a lot of this new respiratory disease at his local hospital. A day later, China then reported this to the World Health Organization that they were seeing large numbers of patients presenting with severe respiratory illness in the city of Wuhan, and the cause of that was unknown. About a week later, China reported that they had identified the cause. It was a new coronavirus, giving rise to severe respiratory symptoms with a high mortality rate. About 3 weeks later, the World Health Organization declared that this was a public health emergency, and a day later, the United States and quickly followed by Australia and other countries started to suspend entry of foreigners into their country who were coming from or who had travelled through China. And about 6 weeks later, in mid-March, the World Health Organization declared that this was a global pandemic because the disease had spread to multiple continents across the world. By that time, there were already 10,000 deaths that had been reported due to this virus, and within 2 weeks of that, there were as many as 100,000 deaths attributed to infection with the new virus. Things progressed very quickly from there, so that by the end of May, there were 350,000 deaths, and by the end of June, 500,000 deaths. Shortly after that, Donald Trump decided to wear a face mask for the first time in Donald Trump himself tested positive for the virus, by which time there were over 1 million deaths recorded due to COVID-19. And so that's got us to where we are today, over 1.5 million deaths now recorded due to the COVID-19 virus, and over 60 million cases of COVID-19 reported across the world. So this has been a massive challenge, obviously, for health systems across the world. Brand new virus, brand new disease, in fact, that had never been seen before, where clinicians are needing to operate in an evidence-free zone or an evidence vacuum, and I guess clinicians needing to fall back onto first principles with regards to how to manage the various organ systems affected by this virus, but key to eliminating the virus is having effective treatments and effective vaccine strategies. And so you will know that we've had all sorts of treatments that have been proposed for COVID-19. Some of them are more sensible than others, but this is a reality that when you have a highly lethal virus that's highly contagious and with hundreds of thousands of patients, that both politicians and scientists get desperate.
Sorry, Tom. You're just coming in and out on your speaker a little bit. I'm not sure whether your headphones are close enough to your face or if there's some background noise going on.
Can you hear me any better now?
It's very similar still.
Can you hear me any better now?
That's much worse.
Yep.
Can you hear me any better now?
That is a little better than the much worse.
Okay. What about this?
Yes, that's great. Thank you.
Right. Okay. So this uncertainty spawned a lot of research activity in the health and medical research space across the world, with many groups across the world informally testing a number of possible treatments and formally testing a number of potential treatments by way of clinical trials. So that as of yesterday, there were 2,500 separate clinical trials that have been registered across the world. Most of them very small trials and unlikely to provide conclusive answers in their own right. A couple of the trials being large platform trials that are slowly providing evidence in particular for the things that don't work, like hydroxychloroquine and various HIV antiretroviral therapies that have been trialled, but occasionally identifying things that do appear to have some effect, like the use of steroids. One of the big barriers to learning in the COVID-19 pandemic is the fact that health systems are not good at capturing data in a systematic way, even for those hospital systems that are using electronic medical record systems. Typically those systems are configured in different ways, and it makes it very difficult to pull data across multiple hospitals. In an attempt to try to collect data for COVID-19 in a systematic way, a group based out of the UK called ASARIC deployed early in the pandemic standardised clinical data case report forms with the hope that this would encourage clinicians from across Australia to record information about the patients that they were seeing in a systematic way, so that data could be used for research and try to understand the disease better and to evaluate different treatments. And so just to give you an idea of the sort of data that is captured in these standardised case report forms, typically the forms are collecting information around the types of symptoms and the signs that patients are presenting with, particularly those patients who are presenting to hospital. They're capturing information on the types of medication that people have received before coming to hospital, and they're capturing information around comorbidities, so that's underlying illnesses or diseases that patients have, like diabetes and heart disease, for example, and other potential risk factors that patients might have. And then in these standardised case report forms, they're typically capturing information about the progress of the patient while they're in hospital, so observations like their temperature and heart rate and respiratory rate, their oxygen saturation, so how well their blood is oxygenated, and also information about the sorts of treatment that patients are receiving in hospital, both medical treatment, but also non-pharmacological treatments like prone positioning, which is where patients are basically managed lying on their front to try to improve oxygenation and improve lung function. And also the sorts of data that's being systematically collected are laboratory measures, and so there's a way of capturing that information both at the time of admission, but also capturing information on various blood parameters over the course of the hospitalisation, and then finally more information about the outcome for the patient, whether the patient died whether the patient was discharged to hospital, whether the patient needed to go to the intensive care unit, and also information about various complications that have arisen during the admission. And so with the benefit of data that's been captured systematically on tens of thousands of patients, there's been a number of efforts to try to use that information for prediction, and the primary focus of those predictive models have been around trying to predict who will die. And so there are two main types of predictive model. There are models trying to predict of all people in the population who is at highest risk of death, and then there are predictive models of trying to predict of those who are presenting to hospital or admitted to hospital, which patients are at highest risk of death. And this 4C mortality score is one such example of a predictive score that's been developed by the ASARIC group, which deployed the standardised case report form that I showed before. And so this is, as I said, a fairly typical model. They've used a type of penalised logistic regression. Out of all the factors, all the variables that are collected in the ASARIC form, they've narrowed down to just 8 factors that they believe to be predictive of the risk of death. Those factors are age, the sex of the patient, the number of comorbidities or underlying diseases or illnesses that the patient has, their respiratory rate at the time of presentation to hospital, the oxygen saturation of their blood at the time of admission to hospital, what's called the Glasgow Coma Scale, which is a measure of their alertness at the time of admission, their urea, which is a blood measure of the function of the kidneys at the time of admission, and the CRP, which is a blood measure of the amount of inflammatory response in the body at the time of admission. And so they break that into a score, and effectively it's quite simple. You just add up the numbers based on how you are categorised against each of those items, and in their validation set of about 40,000 patients, most people score between 5 and 15, so they've got a fairly good spread of scores. And what they've shown in the validation set is that those who have the highest scores have about an 80% risk of death, whereas those patients who have a low score have a low risk of death of 1% or less. So that seems like that could be a very useful tool to implement in practice to try to predict who will die and who won't die. But there are limitations and barriers to use of these sorts of predictive tools in clinical practice. So one of the main limitations is that the score predicts just one thing, and that is the risk of death in newly hospitalised patients with confirmed COVID-19 disease. But for me as a clinician, what if I want to predict the need for admission in the first place? So what if I've got a patient who I'm managing in the community and I'm trying to make decisions about whether this is a patient who needs to be admitted to hospital or whether I can free up that bed space and safely manage this patient at home. This risk score doesn't actually help me with that decision. And what if I am managing patients in the hospital, but I'm not only concerned about whether this patient will die or not, I'm also interested in whether this patient is likely to need to go to intensive care unit and take up a precious bed in intensive care. And what if I'm also interested in the risk that this patient will go on to have some sort of long-term disability if they survive. A model like the 4C risk score doesn't tell me anything about those other important outcomes. The other barrier to using the 4C and similar scores in clinical practice are concerns about the transportability of the model to my particular setting, or the generalisability. So how can I have confidence that the score that's been developed primarily on UK patients will work just as well for me here in Australia, where the pattern and the reasons for referral of patients to hospital may be different. So one important difference potentially is that some patients in Australia have been referred to hospital not for management and for support of their disease, but purely for infection control reasons, so that they're not in the community. Does the risk score apply in the same way to the Australian context? Another potential barrier is that sometimes we're not actually confident of the diagnosis. We might have a patient who has severe respiratory disease, but we may not be certain that this is COVID-19 as opposed to influenza or some other cause of pneumonia. Can I use this score to predict the risk of death in patients who may have tested negative for COVID-19, but who may actually have COVID-19 because they've had a false negative test? Another limitation to this sort of scoring system is the fact that it only uses 8 of the variables that I've collected to make a prediction about my patients. Out of the dozens of things that I know about my patient and that I've recorded and captured in the standardised case report form, only 8 of those things are considered to be relevant to the prediction. But what if I know other things about my patient that aren't captured in the score? What if, for example, I know that this patient has a very high blood lactate level, and I know that very high blood lactate levels are a marker of sepsis? How do I integrate that additional knowledge and information about my patient to the 4C score? Another potential limitation is the fact that it conflates the different comorbidities or the different background conditions in producing a risk prediction. So it essentially assumes that diabetes and heart disease and liver disease and kidney disease and neurological illnesses are effectively interchangeable with regards to the effect on the risk of death, and that's hard to accept on face value. Another interesting part of the score is that the urea, which you'll remember is the blood marker of kidney function, was pulled out as being very important in predicting the risk of death, and that's hard to understand on first principles. So is that because background kidney disease somehow predisposes to the risk of death? And if so, why is that? Is it because people who have COVID-19 die of kidney failure? And if so, why is that? Or is it that COVID-19 infection affects the kidneys so that people who have a high urea, that is evidence that they have a significant viral infection and that they're at risk of dying not because of the kidney disease or the kidney failure, but because they have a significant infection. Other problems with the model: what if I don't have a urea result for my patient, or a CRP result, or an oxygen saturation? What if I have missing values? That at the moment the 4C risk prediction score requires me to have complete information on each of the 8 factors that go into the prediction. And another question is, what if I improve someone's urea, for example, by giving them dialysis or renal replacement therapy? So I can bring someone's urea level down. Does that mean that that will improve their prognosis? By the same token, what if their CRP, their measure of inflammation, improves spontaneously tomorrow? Is that indicate that this patient now has a lower risk of death than they had yesterday? or if their oxygen saturation improves. How does changes in these measures over time influence my prediction that this patient will die? Another potential problem with this sort of model just on face value is the fact that it doesn't distinguish between different phases of the disease. So we have this understanding that COVID-19 has two major phases: an early phase in which the problem is uncontrolled viral infection and viral replication, and a latter phase which is characterised by uncontrolled inflammation to the virus. And a CRP is a measure of that inflammation, so it's potentially a measure of uncontrolled inflammation, but it could also be a measure of a normal immune response to the infection early in the illness. So a high CRP could be both a good thing early in the illness or a bad thing late in the illness. But a simple scoring system like this doesn't distinguish between early phases and late phases of illness, and so is challenging to accept on face value. In short, simple scoring systems and tools have been developed for COVID-19. There are a number of these that have been published in the literature, but at the moment, using these sorts of approaches are relatively of limited value for application at the bedside for making decisions about patients at the point of care. So I'll now hand over to Stephen to discuss what the group has been doing to try to provide and develop tools that are better suited for decision making.
Thanks, Tom. Might just share my screen. Yep. Okay, so as Tom mentioned, obviously the story about what's happening with the patient is changing over time. So we've got here essentially the patient journey kind of in pictorial form. And I guess from our perspective as modelers, we're interested in what's changing over time, what data we're collecting across the process, and what's available from different places. So there's often data available from different sources, sometimes from the testing sources, sometimes from the clinics, the GPs, and sometimes the hospitals. During this patient journey, so obviously there's a progression where things are looking okay if they're in the community. At some point, things might start to deteriorate, and then they start to get in contact with an actual clinical service. At some point, things might get a lot worse, and they get to ICU. They might die while they're there, or hopefully they're discharged. And of course, there's question marks around reinfection and what happens there. During this entire process, there are various questions that different providers will have. So, for instance, primary care providers will have different questions around, false negatives, as Tom was mentioning earlier, and basically, how worried should we be about a particular individual? And then the hospital providers will have different questions again, basically around whether ventilation is required, supplementary oxygen, and if things are getting progressively worse, basically which organ system should we be paying attention to more. So the idea is that our models that we're creating can help answer a lot of these questions at different points of that journey. So when we started this project, we started around March, and so this is basically the number of cases in Australia at that point. So at that point, we were kind of thinking, okay, this is going to get potentially quite scary if we were looking at other places around the world. And so we were projecting out and thinking, okay, things might look a little bit like this. So things get quite severe over a short period of time. And basically, we were thinking that we would need to do a relatively short project, something lasting maybe 3 months or something, before we got something stood up and that could be usable. And so that's kind of what we were aiming at. And we were thinking, we had, as mentioned, we had partnered with a provider who was going to be collecting data. And so we were expecting quite a large amount of data early on. We were expecting to do expert workshops quickly, do that data analysis quickly, and get a model kind of stood up quickly. We were, of course, being a bit more realistic. We were thinking this was a very tight timeline, so we stretched this out a little bit, and we're, obviously going to 6 months over that period, but possibly, hopefully, still creating a model in time that would be useful and of use to people. So the actual journey in Australia was actually fantastic. So we had, we got on top of it really quickly, a lot better than a lot of other countries. We had a second wave, obviously, here in Victoria, which was a little bit more severe, but still pretty tame in comparison to what we've seen around the world. This was actually really fantastic for Australia. Not as great for our project because we didn't have data coming in, which is a kind of strange position to be in. We were quite happy not to have data coming in because that's a good thing, I guess, but it meant the project that had to adapt a little bit to that. So we ended up adapting a little bit. Basically, we tried to organize data from overseas that took quite some time to come to fruition. So that was late in the year. So we mainly focused around the expert workshops and working with experts and trying to get an expert understanding during that original period. So we had a series of workshops, one-on-one sessions, did a lot more validation around the original structure of the models. And then just recently, we're getting into that data analysis and doing some of the model training. And you can see their validation over there. We're just kind of starting that this week, actually. So, so it's just stuck in there now. So at the start of the process, we kind of came together like around that March period and tried to work out what a high-level model framework would look like. So just something to coordinate all of the work that we were doing. So obviously we needed something that was modeling the core mechanism itself. So how the infection gets into the body and how it starts to spread and cause inflammation in the respiratory tract and possibly elsewhere. We needed pieces then to kind of describe what was influencing that core mechanism. So in particular, the individual background factors, as Tom was mentioning, demographics and comorbidities are quite key in how the disease progresses. And obviously age has proven to be, the most key factor, but there's a whole heap of other ones as well. There's other things that can influence this, like the epidemiology and public health interventions, which can affect basically, whether people are wearing masks and, how prevalent things are. And there's also management that people might be doing in the first place. So they might be doing this already without the disease for some other reason, or they might be doing it in response. So we've got various summaries of some of the background factors to work out how severe a particular case might be. And that severity feeds into the progression, which might lead to complications, multi-organ failure, and of course, death. Another part of the story is the testing procedures. So that's obviously quite dependent on the epidemiology and public health picture. And so that turned into a bigger part of the story as we progressed. And then we've got all of the indicators, basically, the biomarkers, symptoms and signs, radiological findings, and so forth. So these are all things that we can use to work out what's going on with this core mechanism. So once we've got all of these pieces together, we can start making some choices. So those choices might be triage, for instance. So we might be saying whether a person's low risk, standard risk, and so forth, and which service they might need to go to. And once we've got this kind of information, we can capture it and embody it in a decision support system or tools for clinicians or for people doing testing and so forth. So that was the basic framework that we had at the start of the process. So The expert elicitation, we did it fairly traditionally, but on a fairly short timeline, I guess, relative to what we normally do. But we had quite a lot of it over that period. So we had our workshops. These worked quite well. So we probably had about 8 to 9 workshops, I think, overall. We had one-on-one sessions, which we developed as a result of essentially some of the limitations in the workshops, which helped us go into things in a little bit more detail. And we also had surveys, of course. So the surveys ended up being possibly of more limited value than the rest, but I'll talk about that in a moment. Of course, all of this stuff was online. I mean, everything in the COVID era is online pretty much, and so all of this was online as well. And during this process, we consulted the literature a lot and made sure that we're still on track. The literature was essentially a fire hose during this period. There was just so much being created, so very difficult to keep on top of it all, as well as all of the extra work as well. And of course, that was online because pretty much everything is online. I'll just quickly describe the process that we took for the workshops. So obviously there was the recruitment. So we recruited, obviously Tom has lots and lots of connections that we were able to draw upon, which was fantastic. We also contacted various mailing lists and a few other people from who were also kind of investigating COVID and working with COVID to try and recruit them into our workshop processes. Basically, for a workshop, we'd do the usual kind of thing. We'd circulate some material, set out what the goals were, tell people what the model was supposed to do, etc. We'd circulate a survey beforehand, and the point of that survey was basically to set the mind frame for the workshop and to identify any issues ahead of time. So they worked pretty well for doing that. Then there was a kind of a fork in the road depending on whether we were starting with a completely blank slate and just trying to create a new model, or we were working with an existing model. So if we were starting with a new model, we'd create our own straw man model based on the literature. We had a lot of on-hand experts as well, which was great. So we were able to kind of create those together with the on-hand experts. And then we'd create a template basically that would capture the certainties in the process. And just the things that were certain. So all the rest of the story basically we'd leave for the workshops. In the workshops, we'd work out what the relevant variables were. We'd work back from the outcome or work forwards from the initiating event, for instance. So kind of pretty typical. If it was an existing model, and we often were starting with an existing model, that was quite interesting because essentially what you're trying to do is focus, get people to focus on the pieces that you're really interested in. So it was really important to simplify what we had with our models just to what we needed for the workshops. And basically just stripping it down, creating some templates for the areas that we're interested in particular. In the workshop itself, we'd start off by telling the story of that existing model. And then we'd essentially let participants start flagging issues as we were telling the story or after the storytelling. And then they'd help us identify missing pieces as well during that story. And we'd try and work on basically improving the model from there. A really important thing to do by the end of the workshop also was to identify what kind of follow-ups we could do. So making sure that we've sounded out people to find out who was willing to help either directly with us straight after the workshop, or to sound out people for future workshops and one-on-ones and so forth. So the workshops had a variety of strengths in the way that we organize them. So obviously there's the typical kinds of things such as, having the diverse expertise all available at the same time and they can bounce ideas off each other directly. That's really useful to have. In the online setting, there was a couple of key advantages actually, which suggested to me that it was actually that it may actually be worth doing it this way in future as well. It's much easier to arrange workshops. You don't have to get people to fly in from different places. You can usually schedule them at fairly short notice. Really convenient in that sense. And in fact, it's actually quite a lot easier to do the live structure modeling because everyone's got a screen directly in front of them. they can, they can feel directly engaged with that. Whereas often with a workshop in person, people are sitting at quite a distance. Some people can see it well, some people can't. They're just kind of simple things like that that made it work quite well. And of course, people can post notes and questions, which as people are doing currently in this particular Zoom. So it's really good to be able to have that process where you've got, a recording of what's going on as well, automatically for you. So there were a couple of limitations. The clinical experts for us were short on available time, so often the workshops had different people showing up at the different workshops. Very hard to do bias mitigation in the workshop setting, particularly on short notice, and particularly with the structural elicitation. There's lots of techniques for actually doing that, obviously, but because of the how short we were on time, it was quite difficult to do. There was uncertainty around COVID itself, and it was an evolving picture. So things were changing from workshop to workshop, which made things interesting. So some of the issues we had with the workshops in particular was that it was difficult to hear from people, and I guess in an online setting, that's particularly true. So one of the ways that we chose to address this was to initiate a set of one-on-ones. The process was pretty much the same as the workshops, and we treated it pretty much formally in a similar way to the workshops, but it was really typically focused on refining some of the existing models that we were creating. So they followed up workshops. We were able to go into depth, so that was really good. In terms of scheduling, it was great because we could schedule it at any point in time. It was really just the modelers, down to the modelers and what their timing, basically. And we could deal with issues like dominance and groupthink. A little bit more time intensive for us, but not that much. And I guess one of the issues was that there was no ability to bounce things off each other during those one-on-ones. So, a lot of times the experts would say, well, it could be like this, but what do other people think? And we'd have to kind of feedback what we'd heard from previous sessions. But it would have been great if they could just kind of bounce things off each other. The surveys turned out to be a little bit more limited in what we were able to do with those. So I guess the goal was basically to support the modelling and the understanding. So it wasn't to directly get anything that we would put into the model, because we were expecting data at some point would help us do that. So this was more around the structure, and it was really to help us support the workshops. Again, it helps us get people into the same frame of mind. Obviously, with the surveys, it's much easier to do things like Delphi techniques, so that's useful. And the limitations, the key limitation with a survey is basically you need to have a fairly concrete idea of what's going to go into that survey. So if you've got a particularly long survey and you've gone off track, it's very hard to get useful responses, and experts may feel like they've kind of wasted time answering a really long survey. So you do trial runs and things like that, but it's still very hard to get agreement, basically. So they're not very dynamic or responsive to expert input. So one of the key ideas that we developed as we were going through this process essentially was this distinction between expert and applied models. So our expert models basically are capturing expert understanding. So they're a database of what the experts understand about the system. They're not meant to be particularly efficient or necessarily something that you would apply straight away. But they're hopefully causal wherever possible. Hopefully they can be sensibly parameterized, and you can use them sort of in a way to do evaluations and regression testing. They're kind of like a stand-in for your expert, really. The applied models are a little bit stricter, so they have to strictly match data sets and obviously your usage scenario. So, so we were hoping to develop decision support systems based on these models. So basically our applied models have to work in that usage scenario where you've got that decision support requirement. Things have to be stricter in terms of the variable and state definitions. Here you're just trying to capture ideas essentially, but here they really have to work for what you need them to do. they're usually simplified in terms of the mechanisms, but they might actually be more complex in terms of the implementation itself, because something might be more efficient if you implement it a certain way. And in principle, they could be non-causal, but if your decision support system has to support explanations, which is what ours do, then most of the time they have to be causal, or it should be easy to recover what the causal story is. So just to give a quick picture of the development story, we've got the high-level framework here from before again. So we created a range of different models. We started off with a core model, and that quickly evolved into a respiratory specific model. We then looked at complications, kicked that off, and that kind of took inspiration from some of the things that we were doing in the respiratory model. But we really focused on this concept of progression and trying to model that. This kicked off some other submodels around the vascular system, and currently around essentially the submodel of the progression model, which is the background model. We explored the immune system. The immune system is incredibly complex, so we had lots and lots of different models. I've got about 5 models represented here, but there was probably more models than that. So we almost had one model per expert. So we kind of gave up on trying to model the immune system in any kind of great detail, took out some of the key lessons that we could from that, and implemented into the progression model and a little bit into the respiratory as well. So that was the story around prognosis in terms of the models we developed there. For diagnosis, we started that a little bit later. We weren't intending to do as much there, but it actually turned into quite a good model in terms of the testing model, which I'll show in a moment. And then we had a few other pieces to that we looked at. And just recently, we're essentially focusing on some predictive models so that we can verify what we're doing with the expert models. So naive Bayes, TAN, structure learned models, and so forth. So I just wanted to quickly focus on basically 3 of those models. And I may go into, say, only 1 or 2 of these, depending on how much time. So with the respiratory model, we had a really kind of an initial simple picture of what this looked like. This was just one of the examples that we were toying with in the first instance. So just at the very start of the project, we kind of sketched this out into more detail, trying to work out what states would be meaningful to clinicians, and starting to tie it to some of the data sets that we knew existed and what they were measuring. We then kind of took a look at some of the other models that we had around pneumonia, and tried to incorporate some of the processes that were going on there. And some key features here were around, say, for instance, the involvement of the bronchi and the pleura. And this kind of dropped out by the time that we got to the first workshop. And so we then started to really focus on the story around the lungs themselves, and also some of the issues around coagulation and thromboses that were kind of emerging as we were doing the modeling. This evolved basically into the current model structure that we have. It's broken up into a few different pieces. So we've got the infection story here. So the virus enters the nasopharynx, and that infects different parts of the respiratory tract. So for instance, the upper respiratory tract, and then going into the lungs, to the alveoli. That can kick off a systemic immune response, and potentially also cause a blood infection or a viremia, which is quite a serious, starts to be quite a serious condition at that point. And these factors together can combine to cause issues with the lungs themselves. So you can start to get leakage in the capillaries. That can kick off basically one of 3 pathways. So this is the first pathway, which was the mechanical pathway. Basically, this is an issue with the lungs actually moving kind of in and out, and actually being able to produce enough ventilation. So that can cause that kind of an issue. It can make the lungs stiffer. We've got issues with potentially gas exchange. So that's where the oxygen's not able to actually get into the bloodstream, or in this case, which is the hypoxemia, or it's the case where carbon dioxide, you can't actually get rid of your carbon dioxide quickly enough, so that's the hypercapnia. And we've also got the thromboses, which can be kicked off. So that turned out to be a really big feature that developed, that turned out to be of serious interest in terms of COVID-19. We've got the complications basically down the bottom. So things like oxygen's not getting into the muscles and the tissues, impaired heart functions, and then all of this leading to multi-organ failure. So we had a fairly comprehensive story of what was happening with COVID-19. It's a static picture, and so there's also basically a dynamic way of looking at this same picture. So we can model each of the organ systems, the pulmonary system, the cardiac, the vascular, and so each of these might be causing immune issues or inflammatory issues, and then giving rise to certain biomarkers and so forth, and symptoms and so forth. So, and we can see this progression over time. So that system, that's influenced by various background factors. And so that system is composed of a few different systems. I guess I'm running short on time, so I won't go into these systems in detail, but basically we've got one, say for instance, for the pulmonary system. The idea is to generalize what's going on, take out the key factors that are currently occurring, so say for instance, coagulation issues or perfusion issues, and then try and essentially work out what that means in terms of the lung function and hypoxemia, or whether a person's low on oxygen. We've also got the symptoms model. This is essentially where we're tying in the available data. So all of the biomarkers, the signs and symptoms, whether a person's got a cough or temperature and so forth. And so this is what we can use to then tie it in. So it's not quite not just an entirely abstract system, but we're tying it to data. And then we've got the testing model. So this is one that we developed later on in the process as it started to become apparent that testing was a really important part of the story. So this is your classic kind of Bayes net setup in which you've got your kind of latent node, whether a person's infected and some observation of that. You've got your true positives and your false negatives, your false positives and your true negatives. So that's your basic story. And what we wanted to do was expand that story. And this is essentially how we expand that story. So we filled in basically at the top here, we've got background factors that are feeding into whether a person currently has an infection. So that's feeding into the prior probability of their infection. And then we've got a whole bunch of factors around the actual testing process itself. So for instance, how good the collection is, what's going on during transport, what's going on with the machines that are doing the testing itself. And these are all feeding into that true positive and false positive rate down the bottom here. So just quickly, we've got now a range of different kind of data sets that we're matching up with. So we've got LIOS, which is a German data set, which we've been working with for probably the past 2 to 3 months. So CDEP was the original platform we were planning to get data from and never did, but we may get some data in future in some form. And ISARIC and IDO are essentially the same data set. This is a dynamic data set, which records things on a daily basis, and we're hoping to get that very, very shortly. We've got conditional approval just recently, so hopefully we can use that to inform our progression model. And for the diagnosis model, we've got data coming from a few different places, Department of Health and Human Services in Victoria, which we're negotiating, and also the Health Hotels program in New South Wales. There's a few different kinds of validation that we're planning to do. So we've already done the structure validation with experts, as I mentioned, not against data, but just with experts. But we're also planning to do various further validation, basically, once we parameterize the model. So we've got this face validation with the experts to work out if the inferences are plausible. We've got the predictive value or performance of the models that we're trying to do. So comparing against, say, for instance, naive, Bayes, TAN, etc. We've also got, and this is quite unique, obviously, to BaseNets and what they're capable of doing, is the explanatory value, and trying to work out, okay, we've come to this inference, and the BaseNet, according to the BaseNet, this is the most likely path towards this particular outcome. So is this an intelligible result? Is this matching what experts are thinking, and so forth? So that's going to be of importance to us, particularly if we try and deploy the decision support system for clinical use. And then we've got the practical value itself. So trying to draw out conclusions in a practical setting. Say, for instance, there might be pressures on time and so forth. So we've got to see if we can do that quickly and on time. So just to summarize, we developed a few things this year so far. So we've developed a key respiratory story around COVID-19. We've developed a progression and prognosis models for hospital patients, and that's we're hoping to get data to kind of finalize that process. And we've developed some testing and diagnosis models as well, which we're hoping to apply pretty soon. So moving into 2021, we've also got, we're basically planning to do some validation around the predictive and progression models. We're hoping to actually create some public web-based endpoints, so API endpoints for people to integrate with. So that will hopefully happen soon. We're developing a sample decision support interface that people might be able to pick up and adopt and integrate into their own systems. And of course, everything keeps changing. So for instance, just yesterday, we had the vaccine actual usage starting in the UK. So that means more model updates generally for us in terms of what that changes and so forth. And by the end of the project, we're hoping to have an applied testing model in different places, in Victoria, New South Wales, and maybe nationally, if that's working well. We're planning to make all of the models available on OSF, and we've got one of those models up already now at this particular tiny URL. We're adapting to overseas settings and seeing if it works in those different settings, and also to, in the longer term view, I guess, is to generalize towards other respiratory infections, so flus and other kinds of severe pneumonias and so forth. So that's basically what we're hoping to do. And that's it.
Thank you very much, Tom and Stephen. That was really fascinating, the journey through the whole of COVID, plus, of course, the fairly high level and quick description of a really broad and impressive set of modelling. We had hoped to have time for questions, and Anchor, I'm going to ask you, do you want to push the schedule back 5 minutes to have 5 minutes for questions, or do you want to move on now?
I think 5 minutes for question would work.
Okay.
If we can keep it at 5.
Yeah, if people could post them and then I'll select them. So I think there was an early question around the going back and speaking to experts, and I think Stephen already addressed that. We have got, is anyone already using any of the models, and who? So Stephen?
Yep, sure. Yeah, so currently no one's using the models directly at the moment, but we've got essentially promises of usage basically from people in Germany. So the guys that we're working with their data sets with, so they're kind of promising to use those. And the testing models in particular, we're very close to getting usage of those with DHHS. So those require a little bit of adaptation to some of the different information that they're collecting, but basically they're very keen to start using that as well.
All right, so there's a couple of really excellent, more detailed questions from B, starting off with, what does it mean to have a forecast on a patient having a high probability of dying? Would that change the treatment? And so I guess that's really around the, and also whether there's ethical issues around whether that prediction of death might influence treatment and then become a self-fulfilling prophecy. Maybe Tom, you could pick up on that one.
Sure. Yeah. No, I think there there is some value in being able to predict the risk of death.
Sorry, Tom, can you speak to the mic more directly? Thank you.
Can you hear me better?
Yeah, that's great. It's just when you look away at your screen.
So there is some value in being able to predict the risk of death. So the reality is that, as you will appreciate, hospital beds and intensive care beds are precious. And so being able to keep people who are at low risk of death out of hospital is of value. So I think there is value in being able to predict who's likely to die, and possibly also where any treatment is likely to be futile. I guess the problem with the existing statistical models is they don't provide any insight into what treatments or interventions might actually reduce that risk. And so I guess a key attraction to the BN approach is not just being able to predict the baseline risk at the time of admission, but also to, over time, as we get better information about the sorts of treatments that are effective and those that aren't, be able to implement some what-if type analyses to see how different choices of treatment might actually reduce that risk.
Thanks. Oh, that question was actually from Anne-Marie B. reposted it to make it easier. So we also had a question from Bruce Marcotte, I guess, around the parameters and levels of susceptibility and risk, and about whether there should be separated for different cultural groups of people who may have differences in those. So I guess that's around splitting up the background factors more detailed. Tom or Stephen?
Is that around ethnic risk factors perhaps, or different perceptions of risk?
I'm not sure. Bruce, do you want to say?
Yes, thank you. I was dealing with the fact that, at least here in the US, there seem to be different cultural backgrounds which have different risk factors or intensities. I wonder if that's being done, or are you throwing sort of all of the cases into a single pot, so to speak?
So I guess, Stephen, we've been limited to the sorts of background and demographic factors that are reported in the standardised case report forms. From memory, ASARIC does collect some information around ethnicity. In some contexts, it's very sensitive, as you can appreciate, to collect data on ethnicity, and so I'm not sure how complete that information is going to be. And as you will appreciate, ethnicity covers a range of things. There's both potential genetic risk factors, which appear not to be terribly important for COVID-19 as far as we can tell, but ethnicity also covers a range of other socio-economic and other factors that are certainly risk factors for acquisition of infection in the first place, but also the risk of having other background diseases and comorbidities that might affect the risk of progression to severe disease. So we will incorporate whatever information we can obtain, but I think that whole background story about how ethnicity and genetics impact on risk of severe disease is still a bit unclear.
Okay, I think that we are now out of time. As Stephen put up towards the end, a lot of the details now of the models and the process are available on the OSF, Open Science Foundation site. If you could perhaps put the link into the chat as well, Stephen, to make it easier for people. And I'd really just like to thank both of our speakers for an incredibly interesting talk and very, very timely, fascinating from a modelling and of course from a living in 2020 COVID year point of view. Thank you very much.